Good afternoon.
Good afternoon. Vijay sir has not joined.
I'll just try sharing the screen once. Huh?
Yeah, you can try.
I hope the full screen is visible.
Not yet. Maybe lag. Little lag is there. Maybe.
Just let us wait.
Can you move forward?
Yes, I have moved. It's not visible.
It is visible. Pneumococcal vaccine slide is there.
But I have moved to the second. Is it the full screen or?
No. It is only, still it is showing not full screen for me.
Okay, I'll stop share and again try to share. Why this is happening sometimes?
Good afternoon, Sagar sir. Yeah, now I can see.
It is full screen now?
Yeah, it
Full
is
screen and second slide this is.
Yeah.
You try to move it now? Yeah, they are moving. Yes.
Moving?
Yes.
First slide. Okay. Okay,
Yeah,
I will
moving.
stop share there.
We hope there will not be any problem today. Yes.
there is some minor problem with Basavaraja sir. He's trying to check it. I have again sent him the mail just now, 1 minute back. If some issue still remains, Surendra sir, you'll have to share the slides from your end.
Yeah. I just kept ready.
Yeah.
I just kept it ready.
Good afternoon, Ganesh sir.
Ganesh, you are looking very smart. Don't worry.
Unmute. Ganesh sir, unmute.
You have to unmute, please.
You have to unmute, Ganesh sir.
Yes.
मैंने बोला कि थोड़ा ये दिमाग के अंदर भगवान ने कुछ दिया होता तो ज्यादा अच्छा होता आप जैसा। हाँ, जयदीप दा के घर में 2-4 साल ट्यूशन लेना पड़ेगा तो थोड़ा सा जिंदगी का कुछ बन जाएगा।
तो ये सब निकाल जाएगा, ऊपर कुछ नहीं जाएगा।
नहीं, फिलहाल ना सीजन इज वेरी अप. That's the reason why probably people are not, they are into mode of earning money now treating patients and earning money rather than learning academics and knowing something.
Ganesh sir, did your slides open yesterday properly?
Yes,
So how you corrected it? What was the technical?
No, actually, it was on Google Drive. OneDrive. From there, I could open it. From the mail proper, From the mail, there were a lot of slides which were not seen at all.
So now you have downloaded it.
Overlapping is there, I think. Something.
Overlapping is there. Huh?
So now when you have downloaded it, it is okay now?
Now it is okay. I downloaded it on OneDrive and then it is okay.
Then it is okay. So that is. Because Basavaraja sir was also having some issue today.
Because it is a large file, no? That is a problem. Otherwise, what happens in other modules, you send one particular topic to that particular speaker. So that becomes a smaller file. Now, here what is happening is you are sending entire vaccinology module to each and every faculty. And that is why it is becoming too big a file.
Yeah, that is the issue. It's a big file, large file.
So what you can do is next time when whichever the speaker is, you will have to segregate these different topics and send his topic only to him. That becomes a smaller file, but that is a tedious job. Tedious job.
Because there are so many faculties and so many sessions, and every time the faculty.
I know, and then there are interchangeability also. One might take the another topic next time, so it is difficult also.
But let us see something.
Or Sagar, what you can do is make it into 2 or 3 parts, part 1, part 2, part 3, and then send it, because then the file size would be a little less and he can open it up.
That will take care.
The 2-hourly program can be divided. You can send it.
Exactly. 2 hourly programs could be divided and sent.
Day 1, day 2, day 3, some
Day
3
3,
sections.
right.
Yeah, we can do that.
Vijay sir is busy.
I hope he remembers. Huh?
Yeah. Morning I have called him.
See, you have called.
Another 1 minute is there.
Yeah, 1 minute is there.
So what shall we do? We'll wait or go ahead with the Jaydeep sirs. I'll just call Vijay sir one more time. Hello, Vamshi. Sir. Same, sir. I think sometimes it will ask to register.
Dr. Vamsi, please unmute yourself. You are not.
Just register it and go.
Secretary sir, please unmute.
Yes, sir. Sir, good afternoon, sir. Surendra, sir. Jaydeep, sir.
Good afternoon. Good afternoon.
Sir. Sir, Surendra, sir.
Yes.
Abdul Mananani, he was reminding you, sir, that your talk is there and he was distributing the cards, invitation cards for 30th.
Okay,
Saturday
no
night.
problem. No problem.
Okay,
Ask them to register.
okay, sir.
Ask them to register for conference.
Okay, sir.
Yeah, sir has joined. Yeah, good afternoon, sir.
Good afternoon, sir.
Good afternoon.
Vamshi, you can start, I think.
So, good afternoon, everybody, and a warm welcome to the second day program of Central IAP Vaccine Module. Issues arising of these vaccines have been nicely dealt yesterday, and it is going to be continued today. I welcome the Central IAP President, Secretary Surendranath sir, Jaydeep Chaudhary sir, Sagar sir, and all other faculty. And I also invite Bakul Parekh sir, Vijay Vale sir, Abhaysha sir, and Ganesh Kulkarni GV sir, who is today's speaker. So may I hand over the mic to Surendranath sir. Over to you, sir.
Yeah, good afternoon, all of you, without wasting much time. So Sagar, can we start? No problem.
Yes, sir. Please start.
Yes.
And even
Yes.
if there are some remaining questions from yesterday's part also, we can take today also, no issues.
Yes, sir. Yes.
So it will be better interaction. Yes.
Yesterday,
first-
almost all the questions were answered, sir. If I know, there were 3 questions which were answered.
So, even moderator can ask question from his own thoughts, even if there are no questions on the chat box. So if there are less questions on the chat box, I am requesting moderator to please ask few questions from his own thoughts also in today's
Okay,
session.
sir. Okay, sir. The
Over to
first
you,
talk
Vijay.
will be on DPT vaccine by none other Dr. Vijay, sir, who is the past president of Central IAP and vaccinologist. Not only that, he is an ID specialist of the country. Sir, kindly take us to the DPT.
Well, good afternoon. Thank you, everyone. Welcome to this second day of the Vaccinology. And today we will be talking about, one of the oldest combination vaccine, which is being used since last several decades. We talk of combination vaccine, but if you look at the DPT, that is the first combination vaccination, it combines antigens of 3 diseases. So All of us are pretty well aware of these basic facts that just to quickly recap, it's available as 0.5 ml used intramuscularly in anterolateral aspect of thigh, stored at 2 to 8 degrees, and it is a very freeze sensitive vaccine. So one need to be a little careful while storing it. And we know the standard schedule of the EPI schedule, which is practiced in developing countries like India, 6, 10, and 14 weeks, the primary series, followed by 2 boosters, one in the second year of life at 18 months, and the the second booster in the 5th year of life, just before school entry. And however, one must immunologically, one must remember that the booster dose given 6 months from the last dose of primary is considered as valid. This is very useful, especially when you have to practice a catch-up schedule in a child who has delayed his vaccines. Now, you have 2 types of vaccines available: the wholesale pertussis containing DPT and the acellular pertussis containing DPT. And not only are these basic DPT combination vaccines available as standalone vaccines, but they are now available with various other antigens in combination with either Hib, hepatitis B, or injectable polio with different permutations and combination. And the antigen content varies in different combination. So this is also important to remember, because there are certain restrictions of use of a particular dose of antigen beyond a particular age. Say, for example, the full dose D is usually not given beyond 7 years of life. What was practiced in the past in government schedule was capital T and small d. So these are the different combinations which are available to us. The wholesale DT-WP is, it contains in combination, which is very much practiced in public health sector in national immunization program, is pentavalent vaccine as Pentavac, which has DTW plus Hib and hepatitis B. The quadrivalent vaccine, which is available, has only Hib and there is no hepatitis B. Whereas hexavalent vaccine, which is available either in combination with wholesale pertussis or acellular pertussis component, you have hexavalent EZ6, which has, apart from this 3 DTWP, it has Hib, hepatitis B, and IPV. This is from Panacea, and now recently Serum Institute also has launched a vaccine which also has wholesale pertussis containing DTWP. And as I said, it is also available in combination with the acellular pertussis containing DPT. So you have DPT plus Hib plus hepatitis B plus IPV. Then there is a vaccine called Pentaxim from Sanofi, which has the acellular pertussis containing DPT. That is, these are 3 antigens. The 4th is Hib and the 5th is IPV. So one must remember that Pentaxim, as compared to what is available in the National Immunization Program, it contains IPV, whereas the pentavalent vaccine, which is used in NIP, does not have IPV. It has hepatitis B and Hib, whereas this does not have hepatitis B. Of course, apart from the basic difference of acellular pertussis and wholesale pertussis vaccine. And then Tetraxim is again a quadrivalent vaccine where the 4th component is IPV along with your DPT, and it contains acellular pertussis DPT. Now, if you look at the antigenic content, what is important to remember that the pertussis component in the TDAP is capital D, small ap, is 1/3 of the antigen which is used in full dose vaccines. Against 25 microgram, it is only 8 microgram. And the D component is 1/10 in this TDAP. So these 2 important things you must remember. Rest of the antigen contents are almost, say, for example, tetanus toxoid is same, regardless of the vaccine that you use. So 1/3 of the pertussis component in TDAP, 1/10 of the diphtheria component in the TDAP. That's why I call capital T, small d, small ap. Now, there are definite advantages of combination vaccine. It reduces the number of injections, obviously translating into less pain. And so the parents are more willing and less anxious about this vaccine. The child's acceptance is definitely better. That leads to increased compliance and increased coverage. It reduces the number of visits. The storage space required obviously will go down with more antigens packed in one single vial or ampule. It also reduces the burden on cold chain. You must remember that when you have vaccination sessions carried out at mass level, hardly 5 to 10% of the vaccination is done in private sector. And many of us who are storing vaccines, we know it takes a lot of space. And you can imagine most of the vaccine which happens in public sector, the cold chain requirement that the government has to comply with. So combination vaccine would definitely reduce the storage space that is required. Then again, the documentation and logistics are also much easier with combination vaccine. The packaging, handling, transportation also are facilitated because of combining various antigens in this combination vaccine. It reduces the risk to both the vaccinator as well as vaccinees, since there is less handling. Imagine DPT, HIV, hepatitis, and IPV to be given as three different injections than given one single injection. So the number of contacts is minimized, and so needle stick injury incidence also goes down. So definitely combination vaccines are preferred over standalone vaccines wherever applicable, available, and possible. What are the protective titers of DP and T components? Protective titers are not very well established, unlike many other vaccines. Protective titers are titers in the serum which have linear relationship with the efficacy. For understanding and for as a surrogate protection of efficacy for diphtheria and tetanus, we take more than 0.1 internal unit per ml as the protective titer, both for diphtheria and tetanus. Pertussis, we really do not know the definite correlate of protection. What is the efficacy data with DTWP and DTAP? Well, let us understand it very well, that efficacy is something which is tried in trial setting, and there are hardly any efficacy studies in our country with both the vaccines, neither with wholesale pertussis nor with acellular pertussis. But yes, we definitely have effectiveness data. We have been using the wholesale pertussis DPT vaccine for last several decades, and we know that the disease, all the three diseases have gone down substantially. So let's not talk about this precise number in terms of effectiveness, but yes, there is a substantial reduction in the disease burden, and the projected efficacy is calculated to be 85 to 90%. As against this, in the Western world, the acellular pertussis vaccine, which came in the market in 1980s, were well studied for efficacy in countries like Denmark, France, Sweden, Canada, etc. But these are not head-to-head trials. These are trials carried out in different kind of epidemiological setting with different components of acellular pertussis vaccine and acellular pertussis containing vaccines of different manufacturers. So ideally, one need not and should not compare one trial with the other. But suffices to say that across all these studies, the efficacy was found to be 85 to 95%. WHO and IAP, ACIP, there is very categorically mentioned that there is no conclusive evidence that number of components in pertussis vaccine matters in efficacy, because in between there was a sort of advisory to prefer 3-component acellular pertussis vaccine over 2-component. But in 2015 position paper, WHO made it very clear that the observational studies have clearly demonstrated no added advantage of additional component. So your 2-component DTAP is as good as your 3-component DTAP. Now, pertussis, one must understand, is a peculiar disease with 3 to 4 cycles of outbreaks every year. It's a cyclical epidemiology. High level of sustained coverage is required for control of pertussis. The recommended doses, including boosters at 18 months and 5 years and 10 years, are required for protection, and coverage should be optimal. So if you understand this, then you will never, sort of get into argument between wholesale pertussis and acellular pertussis containing vaccines. Both vaccines have their own limitations. An ideal pertussis vaccine is still, not available, but whatever is available will work and will control the disease, provided you have, sustained coverage, and all the doses recommended at particular age should be given. So 3 primary, first booster at 18 months, second booster at 5 years, and a booster at 10 years. Wholesale pertussis vaccines have been effectively used to reduce the disease burden since long, with good proven effectiveness. This is what I talked about in the previous slide, that we have substantial decrease in the disease burden. As the common adverse reactions become unacceptable, this is what happened. So, lot of disease, anything was welcome. As the wholesale pertussis containing vaccine became effective, disease went down and the side effects or reactogenicity became unacceptable. So much so that the vaccination was dropped in a few Western countries, and that led to resurgence of all the diseases. So the manufacturers are requested to make something which is less reactogenic, and that is how acellular pertussis containing DPT came in the market. WHO recommends those countries using wholesale pertussis vaccine should continue to do so. And those countries using acellular pertussis vaccine should ensure that optimal booster coverage should be there. So that, I believe, settles the score between wholesale pertussis and acellular pertussis. If you're using WP vaccine, please continue. There is no reason that you should change over to acellular pertussis. If you're using acellular pertussis containing vaccine, don't worry. Don't be shy of using acellular pertussis vaccine. Whether you use wholesale, acellular, the efficacy is good. The duration of protection, maybe with wholesale pertussis, maybe a shade better than the acellular pertussis. But regardless of which vaccine you use, you need to complete the schedule. First, second booster, and the 10th year vaccine. What are the common adverse effects with DTW vaccine? We are pretty well aware of this: local reactions of pain, swelling, erythema, redness, induration, and fever. Unexplained fever for more than 105 within 48 hours has been documented with wholesale pertussis vaccine. Then HHE, hyporesponsive hypotonic episode with collapse and shock-like state, it can also occur. Persistent inconsolable cry and seizures with or without fever. So last three are severe side effects with wholesale pertussis containing vaccine. Not that they cannot occur with acellular pertussis containing vaccine. These, as such, are extremely rare. In my whole practice, I have seen only one case of HHE with wholesale pertussis vaccine containing DPT vaccine. These severe reactions, as such, are not very common, and they are 10 times less common with acellular pertussis, but they can occur with even acellular pertussis containing DTP. Now, advantage of WP-based vaccine is it has a proven safety and efficacy record, has been used in several developing countries over the last several decades, more effective in bacterial clearance. So it is presumed that when you use acellular pertussis containing DPT, it the immune response is skewed towards Th2, whereas when you use wholesale pertussis containing DTP, you have Th1, Th17 response, where the tissue resident memory cells are stimulated, and that leads to a little better mucosal clearance, and that is how it halts the transmission. So sort of sterilizing mucosal immunity is possible with DTWP. So there are thoughts in several pediatricians' mind that use the first dose as DTWP followed by DTAP, so that the duration of protection is prolonged, or in terms of mucosal immunity, this would be better. But these are again have not become standard of recommendation or standard of care. Efficacy for around 10 years, persistence of antibodies more prolonged with DTWP as compared to acellular pertussis, and they are cost effective, because acellular pertussis containing vaccine are definitely costlier. As against the acellular pertussis vaccines, they're less reactogenic, and there's less incidence of adverse effect like febrile convergent hypotensive response episodes. 10 times less as compared to the wholesale pertussis vaccine. And there is a proven track record with good efficacy in the Western world. We said that there is efficacy data available from Western world. We do not have that data in our country. And they are preferable in high-risk children who are at risk of, who have had reactogenicity with wholesale pertussis. Let us talk about the catch-up schedule. We said the primary schedule is 6, 10, 14 weeks. And one who has missed the vaccination, one need not restart. Like any other vaccine, the basic of immunology, there is a memory response, and you carry forward the schedule. Below 7 years, if the child has not received any DPT vaccine, you use a rapid vaccination schedule 0, 1, 2, and 6 months after the last dose. Second booster is not required if the last is given beyond 4 years of age. Whereas in a child who's older than 7 years, obviously you will not use full dose D and full dose P. And what is generally recommended, a child who has not received any vaccine, and if he's more than 7 years, you use a single dose of Tdap followed by TD. In 2019, ACIP has cleared the doubt of using multiple doses of Tdap because it was found to be not very reactogenic. So one can also use Tdap instead of Tdap, TD. So it has been found to be safe. Then between 11 and 18 years, Tdap followed by Tdap or TD every 10 years. That's the catch-up schedule. Now, encephalopathy has been always a point of discussion with DPT vaccine. It can occur and it is no longer taken as contraindication, but it is taken as a precaution for administering subsequent dose of DPT. Most of the cases of encephalopathy which were blamed to be caused by wholesale pertussis component were proved to be channelopathies, Dravet syndrome. So the pertussis component was wrongly implicated. DPT as a cause of encephalopathy, the causality has not been proven. So there is a clear statement from WHO. So encephalopathy from DPT will soon be, in fact, it has been now taken as precaution rather than contraindication. Now, having talked about this basic immunology and the schedule, let us look at a few case scenarios. Can a 2-month baby diagnosed to have CP following birth asphyxia be given DTWP? Yes, certainly the baby can be given because static disease is no contraindication. 5-year-old SP has idiopathic epilepsy and has come for second booster dose. Can he be given DTP? Why not? Certainly he can be given. What about 18-month AB who has had viral encephalitis at 5 months of age? Can he be given DPT? Yes. It's a one-time insult that the baby developed viral encephalitis, and in no way is it a contraindication to use subsequent DPT. MP had a febrile fever at 9 months. Can she be given DPT? Yes, definitely. Though we know that the reactogenicity, the common adverse effect of fever, are less by 2/3 with acellular pertussis containing vaccine. So in this last scenario, a child who has had febrile seizure, one would prefer DTAP so that the risk of fever and fever-triggered convulsion would be minimized. At what age should a 28-week preterm baby receive DPT? This is extremely common scenario, and one must remember that the preterm babies can be given the DPT vaccine as per the chronological age, and there is enough evidence to say that the immunogenicity achieved after primary series is absolutely comparable with the term infant, and you could use both wholesale and acellular. In fact, with the 3-component acellular pertussis containing vaccine, there is good data showing immunogenicity and efficacy in preterm babies. Can the capital D, small AP be used as the 4 to 5 year booster dose? No. The antigen content is less, the immune response is suboptimal. However, if you are pushed to the wall and somebody has inadvertently used it, it may be counted as a valid dose, but ensure that the child is given the 10th year dose of Tdap again. Efficacy obviously would be suboptimal. There is rapid waning of antibody noted, especially for the pertussis component. And so the 10th year dose of Tdap, though it helps to sustain or prolong the protection and has been strongly recommended, the decennial dose of Tdap, that is giving Tdap every 10 years, has been questioned because it is not a very good tool to control the disease in the community, because the Tdap efficacy or protection, it wanes very rapidly. So if one wants to use Tdap to control the pertussis in the community, giving booster every 10 years is not a good proposition. Can DTAP plus IPV combination be used at as 5-year booster? Yes, it can be used, definitely. In fact, IIP has strongly recommended to use IPV second booster at 5 years, because it has been shown that over a period of time, the seroconversion or seroprotection dips to almost at around 90%. And one would like to use a dose of injectable polio as a second booster at 5. That is what the IAP has recommended. And we also use IPV at 6, 10, 14 EPI schedule. And most of the data from the Western world, they have evidence of long duration of protection when IPV is used at 2, 4, 6 month schedule or 2, 3, 4 month schedule. But the EPI, we have 6, 10, 14 schedule that we practice. And the duration of protection is not very well studied at this schedule. So it is definitely important to give booster at 18 months and a second booster at 5 years. How do you go about tetanus prophylaxis in an 8-year-old boy who has multiple abrasions following a fall from bicycle? You ask the history of vaccination and then you decide what is required. Obviously, this child is more than 7 years. So you use this opportunity and you use a combination of Tdap in this child. What about the 10th year Tdap for him? If you remember in the past, if a child received another Tdap within 2-3 years, it was said that the reactogenicity would be higher. However, that also has been cleared. Now, even if the child has received a Tdap as a part of wound management at age of 8 years, it should definitely be followed up with a Tdap at his scheduled time of 10 years. What are the guidelines regarding use of Tdap in pregnancy? Well, fortunately, the FOXI also strongly recommends use of Tdap. This is one vaccine like your influenza, which can be used to protect not only the mothers, but also vaccine ineligible infants against the pertussis. So the antibodies which are made by the mother are passively transferred in the 3rd trimester to the offspring, and the newborn baby is protected against pertussis. And it is definitely important because as the immunization coverage goes up, the opportunity for natural boosting goes down, and these adults, they become susceptible, and the antibodies that they have in their system are suboptimal. So very little is transferred to the offspring. So it is worthwhile boosting their immunity by giving a Tdap in pregnancy. And this table is pretty self-explanatory of the need of TT or TD injection as part of wound management. And for this August audience, we need not spend much time on this slide. So these are the different vaccines which are available. This slide does not contain the Serum Institute wholesale purchases containing hexavalent vaccine, which has been recently made available and marketed. With this, let us there is a TD vaccine of serum here on the second slide, and we know there are 2 Tdaps available, Boostrix and Adacil. With this, let us move on to MMR vaccine. MMR vaccine is live attenuated vaccine. It is available as lyophilized powder, which is freeze dried and has to be dissolved with double distilled water diluent. The diluent should also be stored in the refrigerator, and vaccine after reconstitution should be used within 4 hours. This is very, very important, and it is stored at 2 to 8 degrees. There is no need to store it in the refrigerator freezer compartment. It is given as subcutaneous injection, 0.5 ml. We recommend 3 doses. The IAP recommends at 9 months, at 15 to 16 months, and then the second at school entry. Minimum age after which it can be given is 6 months. In outbreak setting, the measles vaccine can be given as early as 6 months. So since we no longer use standalone measles, MMR can be given at 6 months, but then you don't count this dose, and then you carry on with your recommended schedule. If you look at seroconversion, measles when given at 9 months of age, the seroconversion is only 85%. That means 15 out of 100 children do not seroconvert. And that is the precise reason why you recommend a second dose, which comes at around 15 to 16 months. And that would take care of the 15%. And whereas in the Western world, the MMR is practiced at 12 months of age, where the seroconversion is much better, 95% almost. And however, given the disease burden that we have in our country, this is a sort of a trade-off which is acceptable, and we strongly recommend use of MMR at 9 months of age. Mumps, the immunogenicity, when the first dose is given below the age of 1 year, is not very long lasting. And that is why we recommend 2 additional doses over and above the one which is given at 9 months. So your 16 months dose and the 5-year dose. So the 5-year dose of MMR is essentially to prolong the duration of immunity against mumps. Rubella is a very good antigen, very strong antigen, and seroconversion is as high as 98%, 95-98% with one single dose. So this is the rationale of using 3 doses of MMR. You have different brands available. Pradix contains the Geraldine strain of mumps, whereas the serum vaccine contains Leningrad Zagreb of mumps. And there is a new vaccine which is available from Cadila, Zydus MMR, where the mumps strain is Hoshino strain, the original strain which was used in Japan. With respect to seroprotection, all are on par. There was always a discussion and doubt about increased incidence of aseptic meningitis following MMR vaccine. And most of these vaccines give rise to what is known as chemical aseptic meningitis. And most of these children, they have very short-lasting, fever and subclinical meningitis. And not that it is less common with Geraldine, but not that it doesn't occur with Geraldine strain. It can occur even with Geraldine strain. Priorix is a costly vaccine as compared to these other 2 vaccines. And we have been using serum vaccines for the last several decades and may continue to do so. Now, let us look at a few case scenarios. A pregnant lady in the first trimester was given MMR inadvertently. What do? We know that live MMR should not be given in pregnancy. However, if it is administered inadvertently, it is not an indication to terminate the pregnancy. There is registry which has shown that it really does not harm the fetus. 1-year boy, fever, vomiting, loose motions, ready pulse. He comes in the evening and he had received MMR in the morning session. So what must have gone probably? If you remember, I said that this vaccine is available as a powder. We have to reconstitute and use within 4 hours. Because after reconstitution, if you keep the vial for longer period, since there is no preservative in this vaccine, there is high risk of bacterial contamination, and toxic shock syndrome has been documented in several public sector immunization sessions where there have been mishaps because of toxic shock syndrome. Now, talking about this next case scenario, 1-year boy had febrile convulsion and had fever with rash. He had received MMR vaccine 7 days back. So what could it be? One, it could be the vaccine-induced rash, because it's a live vaccine, and like any natural live disease, one could develop rash in the 2nd week after vaccination. A child developing rash 2nd day following MMR vaccine is unlikely to be vaccine-induced rash. Secondly, if a child is incubating natural, measles and he gets an MMR vaccine, he may not be protected. So this could be a natural infection and occurred before the seroconversion. And of course, the child could be having any other cause of fever with rash. Mother gives history of fever with rash in her child at 8 months of age. Now at 9 months, child is brought for MMR vaccine. How will you manage this child? Obviously, though we understand in the olden days, measles is to be a grandmother's diagnosis, but remember, measles, like rash, can occur with several other viral infections. So you disregard that history and you give the vaccine. And even if the child has had measles, MMR has other 2 components, so the child would be protected. How many doses of measles, mumps, rubella component are adequate in lifetime? We already said that there are 3 doses which are recommended. The 2 doses of measles above the age of 1 year, if the first dose is received below 1 year, is to prolong the longevity of mumps. An 18-month-old child has received 2 doses of MR at 9 and 16 months in EPI. So how many doses of MR would you give this child? Obviously, he's above 1 year. He's not received mumps component. You will certainly give him at least 2 doses of MMR. Okay, and this is given to rubella. 1 dose suffices. He's already received 2 doses of rubella. 2 doses of MR will protect him against measles. So he would be unprotected against mumps, and you will require at least 2 doses of MMR. A 5-year-old child received vaccine in MR campaign 2 years back. Now we know that we had nationwide MR campaign. Now, does he need MMR now, as he has already received MMR 2 doses at 9 and 15 months? So obviously we said that he would definitely require another MMR to increase the duration of protection against mumps. Is MMR vaccine contraindicated in HIV infants? So most of the HIV infants, they are immune preserved in early life. And imagine an immunocompromised HIV infected child getting these diseases. It will be disastrous. So the benefits of protecting against the diseases far outweigh the risk. And there is no interference with maternal antibodies in these children. So MMR vaccine is given in HIV infants at early age because with passage of time, their immunity dwindles and the immune response may be suboptimal. MMR vaccine, being a live vaccine, is contraindicated in severely immunosuppressed patient. Like any other live vaccine, if the child is severely immunosuppressed, one would not use it. An unvaccinated child was exposed to a case of measles 2 days back. Can he be offered measles vaccine? We know the incubation period of measles. It can be given within 3 days of exposure for post-exposure prophylaxis. However, in any of such viral exanthematous disease, you must caution the parent that the vaccine may fail because the child has already contracted the illness before vaccination. But as a thumb rule, remember that if the vaccine is given within 3 days of exposure, it would protect. In case where vaccine is contraindicated, you can use passive prophylaxis in the form of immunoglobulins. So this is all that I had to talk about DPT and MMR. I'm sorry I had to finish on time, and that's why I was a little fast. And these are some basic vaccines which all of us are pretty well aware of and have been using in practice for last several decades. I turn it over to Dr. Surendra. Thank you.
Yeah, we will have the questions after the lecture, sir. Is it okay, sir? Is it okay with you, sir?
No problem.
Next talk will be by Dr. Jaydeep Chaudhary. He is speaking on flu vaccine. And Jaydeep is very well known. He is one of the vaccinologists from Calcutta. The present, one of the contestants for the president-elect post of the 2024. And not only that, he was past chairperson of ID chapter, past vice president of Central IAP in 2019. Jaydeep sir, you can start your.
Thank you, Dr. Surendranath. Good afternoon, everybody. We will step into a very big domain of pneumococcal vaccine because of late we have a lot of pneumococcal vaccines to choose from. I hope my second slide is visible. I have changed the slide. Please confirm.
Yes, visible.
Okay. Thank you. Thank you. Right now, there are about 100 known serotypes of streptopneumonia, but we are more concerned about approximately 20 serotypes which cause disease in human. Now, prevention of invasive pneumococcal disease is the primary aim because pneumococci may infect by 2 mechanisms. One is by the mucosal spread without any bacteremia or invasive disease. It can affect and cause sinusitis, upper respiratory infection, or even pneumonia. And second is the invasive pneumococcal disease, which causes bacteremia, meningitis, distant infection, and also pneumonia. We are more concerned about the invasive pneumococcal disease. For prevention, definitely awareness is important. Decreased indoor air pollution is important. Decreased smoking and exposure to other smoke is important. But regarding vaccines, we have 2 types of vaccines available. One is the conjugate one, another is the unconjugated one. The conjugate vaccine ideally should be used in 3+1 schedule in office practice, whereas the unconjugated one is only for the high risk children and also adults. As per the recommendation of ACVIP, the recommended age for pneumococcal vaccination in immunocompetent children is up to 5 years. But it can be used in older age group also, and of course in high risk and special circumstances, because one particular brand is licensed till adult age. In the National Immunization Program, in the government schedule, the vaccine is used in 2+1 schedule at 6 weeks, 14 weeks, and 9 months. Now, we have the PCV13, the 13-valent conjugate pneumococcal vaccine. Previously, there was the 7-valent conjugate. Now that has been withdrawn. The 13-valent has replaced. It's a CRM197 conjugate vaccine. It contains 13 serotypes, 3, 6A, and 19A are of prime focus that we will come soon. The PCV10 by GSK, available as Synflorix, is conjugated with DT, TT, and NTH1 protein. It contains many 10 serotypes, of which the prime focus is 157A, but it doesn't contain 3, 6A, and 19A. Then we have the PCV10 by Serum Institute, available as Pneumocil with CRM197 conjugate vaccine. It contains 10 serotypes, particularly 6A and 19A, but it doesn't contain 3 that's there in the 13-valent pneumococcal vaccine. Right now, one more conjugate pneumococcal vaccine is available. That is the PCV14, the 14-valent conjugate pneumococcal vaccine marketed by Biological E. It contains 3 and 19A. Additionally, it contains 22F and 33F also, but not the 6A due to certain reasons. But the reason for addition of 22F and 33F in the serotypes is the replacement serotypes when the other serotypes are covered by the other vaccines. Now, among the unconjugated vaccine is the polysaccharide 23-valent vaccine. It contains 23 serotypes that we will again discuss when the serotype coverage comes. Now, in the pipeline, there are PCV15, PCV20, which are not yet available in India, and we can discuss it once it's available. Basically, the choice of vaccine is not primarily on the valency. That means more valent doesn't mean that it's an absolutely better vaccine. In office practice, whichever is feasible, one can use, because the serotype coverage difference is minor. That will come in the slides. Now, this is the comprehensive representation of the various serotypes covered in the different vaccines. Serotype 3 is there in PCV13 and PCV14 of BE, and also in the vaccines in the pipeline like PCV15 and 20, but it's not there in the 2 10-valent PCVs. Serotype 6A is there in the PCV10 of serum and PCV13, but it is not in the other available vaccines. Serotype 19A is covered in all the vaccines except the PCV10 of GSK. And PCV14 in addition covers 22F and 33F also, but it doesn't cover 6A. So these are the comparative composition of the available and PCVs in the pipeline. There has been many studies to detect the serotype prevalence in India. There was a Pneumonet study in Bangalore, a study which was a pan-India, ACIP study, then there was IBIS study, a Vellore study, Delhi study, and SOP study. Now, we just collate all these studies and see the serotype coverage of the various vaccines. May I request to please mute?
Dr. Lakshman, mute. Lakshman Kumar, kindly mute.
Thank you. We will proceed. PCV 13 covers approximately 80% of the prevalent serotypes in India. The PCV 10 of GSK covers approximately 8 to 10% less than PCV 13. And the PCV 10 by Serum Institute covers approximately 2 to 8% less than PCV 13. And the PCV 14 coverage is more or less similar to PCV 13. Now, what is the WHO position regarding the effectiveness of these different vaccines? The net impact or the effectiveness of all vaccines are comparable when used in public health, because there our target is to vaccinate more than 80% population to have a herd effect. So the minor variation in coverage as per the different serotypes covered is immaterial when it comes to vaccinating in the national immunization program. The choice of vaccine depends on many other factors like the cost, the availability, of course, the serotype coverage, the programmatic feasibility, because when it's the national immunization program, the question of multi-dose vial and storage, etc., the space occupied are also considered. But vaccines containing 6A and 19A may have an additional benefit in settings where the disease attributable to 19A or serotype 6C is significant. So these are very important serotypes. So vaccines covering these serotypes are definitely at an advantage. There are definite correlate of protection for pneumococcal conjugate vaccine. This is as per the WHO standard. Any new PCV has to meet the following criteria that is laid down by WHO. One is IgG. Now, IgG for all common serotypes, that is collectively and individually, will be more than 0.35 microgram per ml measured by WHO reference assay ELISA. So this is the IgG. Then comes the opsonophagocytic phagocytosis assay, that is OPA, which is actually the functional measure. The bioassay measures the capacity of antibodies to opsonize pneumococci. This is definitely a better reflection of protection or the function of the antibodies. Here, the lowest serum dilution used in OPA assay is 1:8. Because at 1:8 dilution, more than 50% of the pneumococci are killed. So detection of opsonic antibodies in this dilution has been proposed as a protective against the disease. And these are the two WHO correlates of protection for any pneumococcal conjugate vaccine. Then efficacy, the vaccine type, invasive pneumococcal disease, the vaccine efficacy 80% with confidence interval 58 to 90%. For all invasive pneumococcal disease, efficacy of 58%, confidence interval 29 to 75%. May I request Dr. Sunananath, if you could please call Dr. Lakshman Kumar. I think by mistake he has kept it unmuted. So radiological pneumonia, the vaccine efficacy 27%, clinical pneumonia 69%, acute hepatitis media for PCV10, it's GSK PCV10 34%, PCV13 7%. But most of the available PCVs do not have any efficacy studies carried out in India. And efficacy is approximately 70 to 80%.
1 minute, Jaydeep. 1 minute. Jaydeep, 1 minute. I'll ask the DAAP people to mute. DAAP, Lakshman Kumar, kindly mute. Lakshman Kumar, please kindly mute. Our DAAP people can do.
Okay, now let us continue the schedule of pneumococcal conjugate vaccine. Ideally, the primary series should be started at 6 weeks of age because pneumococcal disease is more severe in infancy and in early childhood. If it started at 6 weeks, then 3+1 is the schedule, 6 weeks, 10 weeks, 14 weeks with a booster in the second year of life. If some child has missed the early doses and if the vaccine schedule is started beyond 6 months, 6 to 12 months, then it's a 2 dose in the first year and 1 booster in the second. If it started above 12 months, then it's 1+1 schedule only. Now, if started after 2 years, then as per the current licensure, only 2 vaccines can be used. One is the PCV13 single dose of 2 years and the PCV10 of GSK 2 doses up to 5 years. But PCV13 can be used beyond 5 years also as per the licensure. Does pneumococcal vaccine have herd effect? May I request the DIP person, whoever is there, to please mute Dr. Lakshman Kumar.
Exception
Dr. Surendranath, could you please call Dr. Lakshman Kumar?
Yeah, I'm telling him on. Yeah, he's not
Does
answering.
pneumococcal vaccine?
I'm not able to mute him because I'm not the host.
Okay, no issue. I'll continue.
DIP people have to do. I've sent a message also.
Does pneumococcal vaccine give a herd effect? Well, pneumococcal conjugate vaccine do prevent nasopharyngeal carriage, which is a major source of spread. So herd effect is noted in unvaccinated ones, especially newborn, non-vaccinated, and in elderly also.
6 months also.
A child, sometimes we encounter this situation, a child has received 2+1 schedule in government sector. That is 6 weeks, 14 weeks, and 9 months. Now at 18 months, the child has come to our clinic. Should this child be offered a pneumococcal conjugate vaccine? No such recommendations at present, because again what Dr. Iole was telling in his previous presentation, because 2 doses was received in 6 and 14 weeks and the third dose was at a gap of at least 6 months, so it acted as a booster dose. So this schedule is enough for this child and need not be given any extra dose. Government offers pneumococcal vaccine in 2+1 schedule, 6 weeks, 14 weeks, 9 months. Why can't we use the same in our office practice? Now, this is a different situation. In our office practice, a child has come to us for the best possible protection against the disease. The 3+1 approved schedule should be used in office practice because it has got better effect against some serotypes like 1, 4, and 5. And immunologically, it is definitely superior to 2+1 schedule. And reduced immunogenicity was noted against 6B, 23 in the window period between 9 months to the booster time. So in office practice, we must continue 3+1 schedule. Just like we are not giving intradermal IPV in office practice, we are giving IM only. So we will continue pneumococcal at 3+1 schedule. What are the limitations of unconjugated vaccine? Now, any unconjugated vaccine are T-cell independent. So there is no memory cell generation. Cannot be used in children below 2 years where the disease burden and morbidity mortality is maximum. They do not have any effect on nasopharyngeal carriage. Does not protect against acute otitis media and also non-bacteremic pneumonias. Efficacy moderate and maximum 2 doses can be given, as more doses cause hyporesponsiveness. So there are various limitations. That's why all the vaccines we are having are now conjugate vaccine. What are the high-risk situations in which conjugate vaccine and unconjugated vaccines are preferred? Like any other high-risk chronic heart disease, particularly cyanotic, chronic lung disease, including asthma, diabetes mellitus, CSF leak, cochlear implant, functional or anatomic asplenia, chronic renal failure, nephrotic syndrome, HIV and other immunosuppressed condition, treatments with immunosuppressive drugs, radiotherapy, and of course, prematurity and very low birth weight infants should be considered as high-risk individuals, though they do not come under special circumstances as per ACVIP. So these are the high-risk situations for any vaccines. If we use both conjugate and polysaccharide vaccine, then ideally, both the vaccines should be used in high-risk cases, but definitely the polysaccharide vaccine should not precede the conjugate vaccine. And there should be at least 8 weeks gap between the conjugate vaccine and the polysaccharide vaccine. Now, after completing all age-appropriate doses of PCV, these children should be administered the polysaccharide vaccine at an age more than 2 years, at a minimum gap of 8 weeks from the last dose of the conjugate pneumococcal vaccine, which can be followed by 1 more dose of polysaccharide vaccine after 5 years from this dose of polysaccharide vaccine. For children 24 to 71 months, if age-appropriate doses are not completed, that is, received less than 3 doses of conjugate vaccine, then 2 doses of PCV13 at interval of 8 weeks, followed by polysaccharide vaccine as mentioned above. Mind you, 2 doses of PCV13, because these are high-risk children. For no-risk children, it is again single dose of PCV13 and no indication for polysaccharide. If 3 doses were received in the past, then only 1 dose of PCV13 followed by 1 dose of polysaccharide. Children 6 to 18 years, single dose of PCV13 followed by polysaccharide vaccine after 8 weeks and 1 more polysaccharide after 5 years. Now, these are the different pneumococcal vaccines that are available, and we are all aware of this. Next, I will move on to the Japanese encephalitis vaccine. Well, Japanese encephalitis as a disease, initially it was thought it's only at the JE belt of India. Now the disease has progressed and more than half of the districts of India are now JE endemic. And this vaccine is given in the National Immunization Program. There are 3 vaccines which are available in India right now. One is the live vaccine, live attenuated, produced by China. That is from SA 1414-2. This is the live vaccine used only in government setup, not available in the open market. Then there is the Varicella derived inactivated vaccine, again attenuated SA 1414-2 JE virus strain. It has got 2 strengths. For 1 to 3 years age, it is 3 microgram in 0.5 ml, and above 3 years, even in adult ages, it is 6 microgram in 0.5 ml. Then we have the inactivated varicella culture derived from the Kolar strain, which is available as a single strength only, and that's marketed by 2 companies, Bharat Biotech and Abbott. The live recombinant vaccine is not available in India. As per the schedule, in the government, 2 doses are given, 9 months and 15 to 18 months subcutaneously, because it's a live vaccine. But even in governments, most of the centers, they are giving the inactivated vaccines. The varicella derived purified inactivated vaccine, 2 doses, 4 weeks apart, minimum age 1 year. Mind you, though government is giving at 9 months and 15 to 18 months for programmatic implication, but in private setup, we can give these vaccines earliest as 1 year only, 2 doses, 4 weeks apart. The other Kolar strain derived inactivated vaccine also above 1 year, 2 doses, 4 weeks apart. There is no indication for boosters as of now, so boosters are not indicated. There are hardly any side effects like any other vaccine. There may be local pain, tenderness, swelling. Sometimes there is mild fever or body ache. Rarely, edema was reported, which was rare. and reported after live vaccine, but equality was not proved. Approximately the efficacy of live vaccine is 70% as per Indian experience, effectiveness 95%, but for the inactivated vaccine, the efficacy is higher. For the Varicella derived purified SA 1414-2, it was 90 to 95% with 2 doses, but the inactivated Kolar strain showed efficacy of 87 to 93% even with single dose. That's why DCGI has approved single dose also, but the ACVIP recommendation is 2 doses for either of the vaccines. This is the IIP recommended schedule. All children in highly endemic areas till 18 years of age and also travelers who are likely to visit the endemic areas during the monsoon season and stay outdoor for more than a month, preferably given JE vaccine. If there are less number of diagnosed or confirmed cases in an area, can JE vaccine be administered in the area? Now, it should be considered where there is a suitable environment for JE transmission, that is presence of animal reservoir, the ecological condition of virus transmission and proximity to other countries or regions with known JE virus transmission. Now, JE is a disease which is mainly transmitted around monsoon. When the fields are flooded with water, there are birds and airborne herons, cattle, pigs in the vicinity. So the JE virus circle is completed with birds, herons, and the cattle. And incidentally, if human beings are bitten by the mosquito, then they are the dead end. This is the environmental situation. What is the best and ideal strategy to use a new vaccine in an area with high transmission? The most effective strategy is one-time campaign, which can be followed by incorporation in the vaccination schedule. An adult can also be considered depending on local epidemiology, because for introduction in a campaign mode, the success is much more, but then it has to be sustained and incorporated in the routine schedule. Will JE vaccine give hard effect? Of course not, because it is not transmitted from human to human. Humans are the incidental dead end host, so it cannot give any hard effect. In an area where mass JE vaccination program was started, a child with encephalitis tested positive for JE antibodies in the serum. How to interpret? Now, serum antibody is not a very good indication because it persists for long. The gold standard is the CSF IgM by ELISA. So only a CSF sample, if tested positive, will vaccination be the priority intervention in case of a JE outbreak? JE is not an outbreak vaccine. Other preventive measures are more important for control of JE. But of course, if the person is not vaccinated, then the vaccine may be started even in an outbreak. Well, is JE vaccine an important vaccine? Now, see, of all the cases of encephalitis, viral encephalitis, only JE is the viral encephalitis which can be prevented by vaccination. And among the viruses, only herpes virus can be treated. So rest all the viral encephalitis cannot be prevented or treated. So definitely when one disease can be prevented, the vaccine is important. And in India, already there are 330 districts, most of the states, which are declared JE endemic, and vaccination has been started by the government. Definitely, we all know mortality and morbidity is very high in JE. It is safe and cost effective. So it should be given in all those districts where it is given in the government setup. And these are the various JE vaccines that we are aware are available. Thank you. Thank you so much.
Thank you, Dr. Jaideep and Dr. Vijay sir, for a wonderful talk on vaccines. I think we'll have a 5 minutes of interactive. Before starting the next session, I would panelists answer this question. They are commonly asked by the most of the pediatricians. So I'll just see what are the questions are there.
Good afternoon, Dr. Vasavraj.
Good afternoon, Dr. Jaideep.
Meanwhile, I request Lakshman Kumar kindly mute if you can hear me.
Lakshman Kumar sir is busy in practice.
Dr. Jaideep, you are the host. You can mute him from your side.
Oh, really?
Yeah.
You can mute him, Jaideep. I will try. Can make Surendranath as a host.
Yeah,
No, that
DIP
mute.
can make me a host or she can mute. Dr. Vijay sir, if he is there, why the HIP is not included in the national immunization program? In the national immunization program, we are not giving HIP at 1.5 years.
What is the question?
So why the HIP is not included in the
Why is not?
immunization
Why?
program?
Hello, I cannot hear.
HIP vaccine is not as a booster, is not included in the NIP, National Immunization Program.
So ideally, HIP should be included as a booster dose, but in the developing countries like India, Bangladesh, Pakistan, HIP is not practiced in the as a booster in EPI schedule. But ideally, yes, it should be included. Because the policymakers are not, very keen on including HIP as a booster. But we know that HIP is a disease with short incubation period, and you require readily available antibodies. So there have been instances in UK where the booster dose was dropped and there was resurgence. But somehow in these developing countries, resurgence is not seen or probably missed out and not documented. So I mean, ideally it should be there, but unfortunately it is not there as a booster dose.
Sir, one more question, sir. If an infant had convulsion after DTWP vaccine, is it a contraindication for next dose or should we shift for a acellular pertussis vaccine?
As I said, it is not a contraindication, but you need to be a little more cautious and preferably prefer a acellular pertussis containing vaccine, because this common adverse effect of fever, induration, etc. are much less with acellular pertussis containing vaccine. And as I said, even if you use acellular pertussis vaccine, the protection is not lifetime. So to ensure that all the doses, recommended doses are taken by the child, especially the 3 primary, first booster, second booster, and 10th year Tdap.
One more question, sir. Is there any relation with the birth dose of hepatitis B for using a hexavalent acellular pertussis vaccine?
Is there any contraindication?
No. Is there any relation with the birth dose of hepatitis B?
No,
If
birth dose of hepatitis 1
birth dose
is
of hepatitis B. So,
and use of hexavalent. So there is no contraindication. In fact, birth dose should be given as early as within 24 hours of birth. Unfortunately, many institutions it is still not followed. And in the past, it was recommended as 016 schedule. But with the advent of combination vaccine, 6, 10, 14 weeks doses are practiced. So now that we as such use 3 additional doses, regardless of the maturity and weight of the child, the birth dose is given and the child gets 3 additional doses. This giving additional dose is not does not cause any harm. The antibody titers really boost up well, and it does not cause any harm. So there is no contraindication or no issue in giving an additional dose, even after giving a birth dose of hepatitis B. Now with acellular pertussis containing vaccine, especially the GSK's vaccine, there was a study where it was documented that if the birth dose is not given, one must give an additional dose in the second year of life. So because the seroconversion goes down. But that is not the scenario in our country. All the babies receive a dose at birth. So one need not worry. And we followed up with 3 primary doses.
So in the primary vaccine series, sir, somebody has received a wholesale vaccine as a first dose. The parents are scared of adverse events following the WP vaccine. So can we switch over to the acellular vaccine?
Definitely. You can switch over. You can use whole schedule with acellular pertussis vaccine. I made it very clear that don't be afraid and don't feel shy of using acellular pertussis vaccine if your parents are not accepting the reactogenicity of wholesale pertussis vaccine. At the same time, if you are comfortable, parents are comfortable, there is no reason to switch over to acellular participation.
So
Either way,
WP vaccine can be switched over to the acellular.
definitely, definitely.
Next comes, I think you have answered one question, sir. What is the new hexavalent WP vaccine? It is already there, I think.
Yeah.
Suppose what if the schedule for a hexavalent vaccine for the infant who comes?
Your voice is breaking. I could not hear you. Hello?
Schedule for a child who comes after 6 months.
Surendra, I'm sorry, I can't hear you. There is break in the voice. Hello?
Can you,
Can you repeat the question? I was unable to hear you.
So what is the schedule for an hexavalent vaccine for the infant who comes after 6 months of age?
After 6 months of age, again, if the child has not taken any vaccine, you give 0, 1 and the 6, the third dose. You do rapid vaccination.
Should we give 3+1 or 2+1, sir, above 6 months?
Above 6 months, you can use 2+1.
Okay, sir. Every 10 years, Tdap vaccine to be given as a catch-up schedule for above 10 years of age.
Yes, I said that Tdap vaccine can be given above catch-up, but you can either use Tdap, TD, or you can use Tdap. Tdap will be a costly affair. But at the same time, TD is not available many times. So one can safely use, need not worry about increased reactogenicity. All 3 Tdap is also fine.
I have a tricky question, sir, for you. The child is 3 years, 10-month old, who has not received any vaccines. As per you, after 4 years, it is second booster is not required. Okay, for this child, how should we go?
So if the child has not received any dose, use 0, 1 and 6 months dose of full dose DTWP or DTAP, preferably DTAP because reactogen is higher at higher age, and then follow it up with a Tdap booster at 10 years of life.
So we will give, okay, sir. Regarding the MMR vaccine, sir, a student comes to join in US university, he comes with a university form for the certification of MMR vaccine. He doesn't have any record of MMR vaccine, previous records, but the mother says that he has received the MMR vaccine. Should we give the certificate or?
First of all, most of the students who are in that age of 20, 21 years have received only one single dose of MMR in the past. If they have received it in the public sector, they have not received any MMR because recently we changed from measles to MR. So if the vaccination has been done in government setup, it is very, very unlikely that the child has received MMR. And if the child mother strongly recollects that he has received a dose of MMR, he must have received only one dose because for a 20-year-old child or 21-year-old adolescent, it is unlikely that he has received 2 doses in the past. So you must insist on giving an additional dose and then certify. I don't certify if there is no documented record in my personal practice.
If there is no document, you mean
I
to
don't
say?
certify. Yeah, I don't certify.
Okay. If a child received MR vaccine at 9 months, if he comes to our clinic at 15 months, so
if the child comes at 15 months, I'll give him minimum 2 MMRs. As I said, mumps you have to give at least 2 doses. If the child has taken the first dose of mumps after 12 months of age. So now that this child is 15 months and has received MR at 9 months, he has not received mumps vaccine at all, he will require 2 doses of MMR. One now and one at school end.
Because ACBAP says 3 doses, 9 months, 15 months, and 4 to 5 years.
So as I said, 2 doses of MR that child has received. So 2 doses of MR will give good seroconversion against measles and rubella. The child remains unprotected against mumps. And 1 dose of mumps would not last long. Having given the first dose of mumps beyond 12 months of life, 2 doses should suffice. It will give good, duration of protection.
Okay, sir. Can we give MMR vaccine to the child with nephrotic syndrome?
Nephrotic syndrome child, yes. Unless the child is in full dose steroids, then you would like to wait and then give it once he's switched over to physiologic dose of steroids.
So if he is not on steroids, it is not a contraindication.
No, not at all.
Okay. So we'll go to the pneumococcal vaccines. Dr. Jaideep, sir, you have already clearly explained why 2+1 in NIP, why 3+1 in SCVIP.
Yes, I think there is nothing more to add, because when a child comes to our clinic, we are entitled to offer him the best possible protection. And definitely 3+1 schedule is immunologically superior. The 2+1 in the national program is due to other reasons, a programmatic reason. So we must stick to 3+1.
In the national immunization program, do you think it is essential to give one more dose between 15 to 18 months, either PCV13, because he received only PCV10 during the first 3 doses in the national immunization program?
Ideally, no, because there is a very minor difference between these different vaccines, minor difference in serotype coverage. Ideally, no. But immunologically speaking, we will not be at a fault if we give one PCV13, especially if the child is above, say, 18 months, because one more dose of PCV13 will give some additional coverage and boosting also, so that the antibody titer may persist for up to 5 years. So there is some immunological advantage, definitely, but programmatically, it is not indicated.
Okay. So somebody has asked, the new PCV14, can we give after 2 years?
No, actually, it's not licensed. It is licensed for the primary series only, as of now. And the primary series is 6, 10, 14 weeks. So as of now, it is only licensed for primary series, and we cannot give beyond 2 years.
So another question, switching over from PCV10 to PCV13 to PCV14.
Again, there is a very minor difference. Now, see, the conjugate protein wise, the new PCV10 and PCV13, they have the same conjugate protein of CRM197. So in that way, these vaccines are similar, except some additional serotype coverage. But ideally, if we have started with one vaccine, then better to continue with the same vaccine. So better to continue complete the schedule with the same vaccine.
In your talk, there was one point was there that BLBW babies should receive an unconjugated vaccine also, because they are high-risk children as per the SCVIP recommended. So should we advise them, very low birth weight babies, an unconjugated pneumococcal vaccine 2 years?
See, number one, there is no ACVIP recommendation of giving unconjugate vaccine beyond 2 years in very low birth weight babies, because among the high risk chart, it doesn't feature. But definitely the very low birth weight babies are high risk. And when once they cross 2 years, then one dose of unconjugated vaccine can definitely be given to them.
That recommendation
Dr. Sagar wants to make some points.
Yeah.
Please unmute.
We can put very low birth weight babies in priority group, but they are not a part of high risk group, as Jaideep sir has said. So there is no recommendation to give an unconjugated vaccine to very low birth weight babies.
Okay, thank you. Thank you very much, sir. I think very good interaction. If any questions are there from Sagar Kulkarni, if you want to add anything, you can.
I wanted to ask Jaideep sir, do you think that the 6B serotype in PCV14 is giving very good cross protection to 6A, as what is being shown?
No. As per the studies that we have, the cross protection is not that good as the direct protection. So definitely 6A direct protection is, of course, better than the cross protection that we can have with 6B.
Because there was some concept.
Can I add
Yes.
something, Sagar, here?
Yes,
See, one, first and foremost, direct antibodies are any day superior to cross protection. One. Secondly, when it comes to invasive disease, it really doesn't matter. 6B has been documented to protect disease caused by 6A. However, as far as transmission or nasopharyngeal carriage is concerned, mucosal disease. For mucosal disease, what you require is higher concentration of antibodies. Antibody titers need to be very high. That may not be achieved with 6B against 6A. Again, there are a few studies from Egypt where they have said that even the mucosal disease and nasopharyngeal carriage has been impacted with cross antibodies of 6B against 6A. But ideally, one should have very high titers of direct antibody to prevent a mucosal disease. And most importantly, the antibodies of 6B will not prevent disease caused by 6C. We do not know the exact burden of 6C at this point in time, but the 6A antibodies are better in handling disease caused by 6C as compared to the antibodies produced by 6B.
Thank you, sir. We are running short of time. Now I request our President-elect, Dr. Basavaraj sir, to proceed and give a talk on HPV and I think varicella and one more vaccine is there. You can.
Varicella and meningococcal vaccine. Yeah. Is my slides are visible? Surendranath?
Yes, sir. Visible. Make it in a, yes, sir. Clear.
So thank you so much, Dr. Sagar, Dr. Vijay Avle sir, Dr. Jaideep and Surendranath for an excellent module and excellent interaction. So what I'll be discussing for the next 25 to 30 minutes about the two important vaccine. One is about varicella and another is meningococcal vaccine. First, let us take about the varicella vaccine. So we all know it is a varicella vaccine. It is a live attenuated vaccine. It is derived originally from the Hoka strain. That's the thing in almost all the vaccine. It is in a lyophilized form reconstituted with a distilled water. We need to give it subcutaneously. When you look at the minimum optimal infectious virus content in this one, between 500 to 3000 PFU, recommended age of administration, minimum age of recommendation should be given after the age of 12 months. But ideally, you can give it around 15 months. Minimum interval between the two doses of vaccine as per the ACUAP, it should be at least minimum of 3 months. If you are giving a vaccination after the age of 12 years, 2 doses, minimum interval between 4 weeks to the 3 months between the 2 doses of the vaccine. No need to give a varicella vaccine once the disease which is already been occurred and where the immunity has already been established. That's what we need to be looked at. So another common question, which is we all face it in clinical practice, is post-exposure prophylaxis. When to be, if it is given within 3 days, your efficacy is around 90%. Up to 5 days, it is around 70%. Behind that, it is not really that effective. Use by any brand, because no varicella vaccine which is WHO pre-qualified, it can be stored between 2 to 8 degrees. No need to keep it in freezer unless your space storage is some of the issue, or if you want to store it for a longer period of time, that's the time where you can use it. Otherwise, you can you can avoid in a freezer. Coming to the efficacy of a vaccine is concerned, when you talk about efficacy, first and foremost thing, we need to look at the seroconversion. If you give in a single dose of a varicella vaccination, your seroconversion rate will be around 86%. That seroconversion will be 98% if you give in a 2 doses of a varicella vaccine. Let's look at the clinical efficacy. When you look at protection against a mild disease, almost with a single dose, you can achieve in a 70 to 90% of effectiveness against the mild disease. If you given it 2 doses, it is almost 98.3 against the mild disease. When you look at a moderate and severe disease, so even single dose is more than 95% of the time it will give you a protection against the moderate and severe disease. If the baby takes any 2 doses, that means almost it is 100% efficacious against the prevention of moderate to severe disease. That's about the seroconversion and efficacy of the vaccine. With this background, let's look at some of the clinical case scenarios, what we all come up. This is a 7-year-old son who had a varicella. Mother wants to know if she can protect the 4-year-old son and 9-month-old daughter. What will be your answer to this? As far as we all know, the ideal age is 15 months to give the vaccine, but minimum age is around 12 months. This child is around 9-month-old daughter. It may not be, vaccine may not be advocated. As far as the 4-year-old child is concerned, yes, we can give in 2 doses of vaccination, 3 months apart. That will be that is the way you can protect it. What about immunoglobulin and acyclovir? Generally, we don't not required unless the child is immunodeficient. That's the time where immunoglobulin or acyclovir can be used for the prophylaxis for prevention of varicella thing. Let us look at the other clinical scenario. This is a child who developed 5 to 6 lesions of maculopapular rashes after 10 days of vaccination. This is one of the common scenario. We all get it in practice. The question comes, is it a breakthrough varicella or is it a side effect? Anything which is occurring less than 6 weeks. So most of the time we can say it is either it is an effect of vaccination or it could be a disease which was occurring during the incubation period. That's what this type of rashes, which can be seen in around 3 to 7% of the vaccinated kids. What we need to do in the practice is keep watching the progression. No, if the progression is occurring, that's the time where you can say no need for the second dose of varicella vaccination. Patient might have been in the incubation period when the vaccine was administered. That may be the reason where the natural protection has been acquired through in this infection. Let's look at another scenario. This is a child who developed 20 lesions of maculopapular rashes. Remember, this is after the 2 months of vaccination. That's very important. When was the rashes is developed? Previous one, it was developed after 10 days. This is after the 2 months. So this is a very classical case of a breakthrough varicella. So that's the one thing. When you look at the duration, it is 6 weeks after the vaccination. If the child develops a maculopapular rashes, that is more likely to be breakthrough varicella. How different from that of a natural disease, breakthrough varicella? Breakthrough varicella will have a less fever and intensity of rashes will be less, and duration of illness is also be shorter period of time. Remember one thing, so even the varicella natural disease or breakthrough varicella, both are infectious, they can transmit the disease to the others. So that's the important thing. Generally, we get it around 10 to 15% of the children who has been vaccinated, still they can get a breakthrough varicella. That is the reason why ACVAP committee came out with 2 doses for preventing the breakthrough varicella. Once after understanding the adverse effect of the varicella vaccine and also breakthrough varicella, let's look at the second dose of a varicella vaccine when it is preferred. Usually looking at all these things, breakthrough varicella into the consideration. That's the reason why 3 to 6 months after the first dose of a vaccination. Because breakthrough varicella, which is, it could be because of primary vaccination failure, or it could be waning of immunity, where what we call it as secondary vaccination failure. Titer generally in once the vaccination is given, generally it will be persist for 9 to 20 years after the first dose. Waning is unlikely. Drop in the effectiveness of the maximum within the first dose, and thereafter the remains the same for even for the 8 years. Seroprotection rate and 10-fold rise in the geometric mean titer, which is noticed in a second dose of a varicella vaccine, regardless of the interval. So cell-mediated immunity, which has been reflected with the superior MSI. Basically, cell-mediated immunity with vaccination usually generally persists for till the age of 50 years. As the advancing age, that's the time where cell-mediated immunity is likely to go down. So that is the reason why after the age of 50 years, some of the patients still you can get a varicella zoster. Globally, when you look at the varicella things, which is basically almost second dose is concerned, more than 20, almost 23 countries out of 36 countries administering the second dose of the varicella vaccine in the shorter period of time. Reason being is one, early preschool, especially Montessori and all these things, which is going to start very early, especially in the metro cities and tier 2 cities too. So that's the reason breakthrough varicella is very common and spread is common. Earlier, the second dose within the duration of 3 to 6 months, that's way it will be given a good thing. Give whatever it is best for the individual. Let's look at the varicella zoster immunoglobulin indication. When we talk about indications for varicella zoster immunoglobulin, newborn which has been delivered to a mother with a varicella for 5 days before or 2 days after the delivery, your varicella zoster immunoglobulin will be more effective. But the thing is, it is not really available. That's the thing we need to remember. If it is less than 28 weeker or less than 1000 gram, where the exposure to varicella is there, that's the time, yes, varicella zoster immunoglobulin, we can give it. More than 28 weeker preterm, if the mother is a seronegative, that's very important. Mother is not been exposed to the varicella. These are the patients we need to give a varicella zoster immunoglobulin. Immunocompromised, exposed to the varicella case, yes, you don't take a chance, give a varicella zoster immunoglobulin. Pregnant women exposed to the varicella, especially the first trimester. So congenital varicella syndrome, which is a no, we need to give a varicella immunoglobulin in that also. Let's look at the varicella vaccine for protection against the zoster. When you look at a natural infection and the varicella zoster vaccine, you take those two things into the natural infection, more likely to have a zoster as compared to that of a vaccine is concerned. So, but with vaccine, there is a reduced virus for reactivation, less robust replication, the lessens the problem of herpes zoster in the vaccine as compared to that of a natural infection. The vaccine virus is not well adapted to the growth in the human cells at a normal body temperature. That's the reason. These are the different type of different companies which is coming with this: Verilrix, Verifed, Nexipax, Biovac, Juvicilla. These are all the things where different brands which is available. IAP does not recommend any brand specifically because not all the brands are not pre-qualified. You can use whatever the brand you like, you choose to be. After discussing about the practical aspect of a varicella vaccine, let's look at the meningococcal vaccine. This is one of the other important vaccine nowadays where most of the time pediatrician is interested to look to know about this. When we talk about meningococcal vaccine, there are two types of meningococcal. One is a polysaccharide vaccine where T cell independent, not to be given below the age of 2 years. That is one. Second is meningococcal conjugated vaccine. It is a T cell dependent, can be given below the age of 2 years. All the conjugated vaccine can be given below the age of 2 years. So so and so in case of meningococcal vaccine too. These are the two different brands which is available in India. Menectra, we know that Sanofi Pasteur, and GSK is Menvia, it is the lyophilized form, whereas the Menectra is the liquid form. These are the two brands which is available in the market. Which are the different formulations which is available. Let's look into this. So one is the monovalent, basically it covers the A serotypes. Meningococcal C with IP combination is another thing. Meningococcal B monovalent, mainly protecting the B serogroup. Bivalent A and C serogroups are quadrivalent A, C, W, Y. This is the things which we are all using it. Of these, only two formulations of conjugated vaccine. Both the conjugated vaccine like ACV, ACWY, which has been marketed by Menectra and Menvia, both Sanofi and GSK. Schedule of, when you look at the schedule of meningococcal vaccine, in a children's between 9 months to that up in 23 months, Menectra is given in a 2 series, 3 months apart. If you are using in less than 2 years, more than 9 months, it is the 2 doses of vaccination. Individual with the 2 years to that up 55 years, where Menectra can be given as a single dose. So this is where most of the time you will get an adolescent children who want to travel to the USA and all. That's the time where you can give just a single dose because it is above the 2 years, below the 55 years. In India, where the Menvia, that is MCV CRM, which is licensed to use only in above the age of 2 years, it is a single dose vaccine. Both the vaccines are single dose above the age of 2 years. Let's look at is there any need for the booster? Let's look into this. As far as the booster meningococcal vaccines is concerned, basically can be given only those who have the continued risk of meningococcal disease. That means basically the children who are the risk for meningococcal disease. In that situation, yes, you can. Single booster dose may be given to an individual between 15 to 55 years of age at a continued risk of meningococcal, if at least it usually lasts for 5 years period dose as compared to that. In those children where the primary series has been started before the age of 7 years, first booster dose can be given after the 3 years. Subsequently, every 5 years you can give with that gap of a thing. Let's look at the ACVIP recommendation. So what the recommendation? As far as when there is a disease outbreak, in that situation, yes, vaccination to be given along with the chemoprophylaxis for all the close contact with the patient. Single dose is good enough. High-risk children, where especially children with a congenital or an acquired immunodeficiency, particularly with the children with the terminal complement component deficiencies like C3, C5 to 9, propyridine, and factor D and factor H deficiency. In that situation, yes, it needs to be. Those with the functional or anatomical asplenia, including sickle cell disease, we need to give a meningococcal vaccine. Children with an HIV infection, answer is yes. These are the high-risk children where it requires a meningococcal vaccine. Let's look into the laboratory personnel and healthcare workers who has been exposed to the Neisseria meningitis cases. Single dose of meningococcal vaccine is recommended. Booster can be given every 5 years if the exposure is an ongoing, where the laboratory personnel is involved in meningococcal lab involvement. When you look at adjunct to the chemoprophylaxis in a close contact of a patient, where the healthcare workers in contact with a secretion or an household contact or daycare, single dose of appropriating group of meningococcal vaccine is recommended in that terms. So let's look at what the WHO recommendation. When you look at the WHO recommendation is concerned for the mass immunization, it is categorized WHO in the position paper in 2011. It categorizes a low risk, moderate risk, and high risk. And depending upon the number of a caseload, if the number of cases is less than 2 cases per 1 lakh, it is in a low risk. Moderate risk is in a intermediate risk is a 1 between 2 to 10 per cases per lakh population, whereas more than 10 cases, which is a more of a high risk population. When it comes to the India, it belongs to the low risk cases. That is the reason where IACVIP clearly recommends to the meningococcal vaccine to be given to the high risk category only. It is not for the mass immunization of MCV is concerned. So let's look at the few cases. This is a 10-year-old female with hereditary spherocytosis, is going for an planned splenectomy. She was received only the universal immunization program vaccines. What precautionary advice would you provide to our parents regarding the meningococcal vaccination? This is a very important thing. This is the common thing we have. All patients who has been planning for this one, appropriate live and inactivated vaccines, whatever it is indicated, we need to give. But apart from that, what is important when the children who is going for splenectomy is pneumococcal vaccine needs to be given. Which one do you use? Do you use a conjugated or do you use a polysaccharide? You can give a conjugated vaccine of a pneumococcal 13, which is followed by 8 weeks later. You can give a polysaccharide vaccine of 23 valent, which can be given. That is, one is a pneumococcal, which is planning for a splenectomy. Apart from that, other capsulated like Ib vaccination needs to be given. So meningococcal vaccine, that's what we are interested. Let's look into the meningococcal. 2 doses of meningococcal vaccine needs to be given 8 weeks apart, and 1 single dose of a typhoid vaccine. These are the vaccination we need to give it. If the patient who is planning for a splenectomy, it could be because for a sickle cell, or it could be thalassemia, or for any other reason. If you are planning it That's the time where the pneumococcal vaccine, meningococcal, Hep and typhoid vaccination, apart from the routine vaccination, which is necessary for the patient who is undergoing planning for an splenectomy. Complete age-appropriate schedule needs to be given 2 weeks prior to the splenectomy. That's the thing. Let's look at the, does the child undergoing cochlear implant needs a meningococcal vaccine? When you look at this thing, cochlear implant is concerned, this is a 13-valent pneumococcal vaccine, which is followed by 8 weeks later polysaccharide pneumococcal 23 vaccination that needs to be given. Pneumococcal, there is no controversy. And as far as the H influenza, yes, we need to give a conjugated vaccine, needs to be given for the cochlear implant patient who is planning for cochlear implant. Schedule should be completed 2 weeks prior to the surgery. Let's come to the meningococcal vaccine is concerned. Even in a cochlear implant, there is no clear-cut evidence to suggest that where cochlear child who is undergoing cochlear implant need a meningococcal vaccine. There is no cases of increased cases of meningococcal meningitis which has been noted. That's why it is not been recommended in this case. No specific. If you are giving routinely, that's fine, but it is not specifically recommended for cochlear implant. Whereas pneumococcal, answer is yes. H influenza is yes. Meningococcal, no such specific recommendation to that. Let us look at this is a boy. This is the other common scenario we all come across. This is a 22-year-old boy going to the USA for further studies. What about his vaccination against meningococcal, specifically about meningococcal? US universities generally recommend the meningococcal vaccination to be given for incoming students. That's the general recommendation. When it comes to the which one to use, we have a 2 vaccination, both are quadrivalent, so we can give a single dose of meningococcal vaccine, quadrivalent meningococcal. What is the US recommendation? When you look at that, adolescent vaccinations is concerned 10 to 11 years, 1 single dose, which is followed by booster at the age of 16 years. That's the recommendation in the US. Vaccination is not routinely recommended above the age of 21 years unless they are in a high risk category. So with this, I'll stop here. If there are any questions which is related to the varicella vaccine and the meningococcal vaccine, we are happy to be discussed with that. Dr. Surendranath is there, my Ganesh Bhai is there. So always our vaccination master Ganesh Bhai.
So we'll take up the questions after Dr. Ganesh Kulkarni's talk.
Yes,
because I didn't say Ganesh talk should have been before the Basaraj, but no problem. I think Ganesh will not feel bad, definitely. I request him to start talk on typhoid and hepatitis A.
Good afternoon. Always happy to receive this baton on vaccine talks from my most favorite IAPN, Dr. Basavaraj sir. You know, it is a respect to continue this baton further. This is a particularly very close to heart digital platform, and I'm fortunate to be here. Thank you, Surendranath sir. Thank you, Central IAP, for inviting me here. I'm fortunate also to lead this discussion on 2 non-NIP vaccines, one of them being typhoid vaccine, the other is hepatitis A vaccine. So let's begin with typhoid vaccine. TCV, that is typhoid conjugated vaccine. Probably the biggest breakthrough that came early in the field of vaccinology was this method of conjugation. And this method of conjugation was actually a boon for the epidemiologists, because the polysaccharide vaccine, which was not available to be given for all the kids below 2 years of age, this conjugation process has made it available, and it made these vaccines immunogenic in infancy, because where the disease burden was much higher. Now, there are 3 different attributes when you conjugate a polysaccharide molecule to a protein carrier, because that's how a T-independent vaccine becomes a T-dependent vaccine. And thereby, we have first thing that happens is it becomes immunogenic in infancy. Second thing is there is a lot increase in the IgG response, by which there is a prolonged protection, so that the protection goes on for years together. And the third attribute, the most important attribute, is basically it induces the immunological memory. And that is why these conjugated vaccines are far better and acceptable than these polysaccharide vaccines. Now, this PCV, typhoid conjugated vaccines, is licensed up to the age of 45 years, right from the age of 6 months to 45 years. 0.5 ml intramuscularly it has to be given. Efficacy is almost around 87% in human challenge studies. This is again the Maryland typhoid human challenge studies, which was a very crude way of finding out the efficacy, which is no longer being done now. But it proved the efficacy is almost to the tune of 87%. The zero efficacy showed that it is 85%. And the data from Nepal showed that efficacy was almost 81%. So more or less, it is the efficacy ranges from 81% to 87%. So a single dose of TCV 25 micrograms from the age of 6 months onwards is recommended. There were a lot of debate initially that 5 microgram was also available, 25 microgram also is available, which one was better and more pertaining to the vaccinology. But then all the Vietnam studies has proved that 25 microgram is the most suitable one, and that's how we have come to 25 microgram dosage for TCV. Now, the routine booster for TCV at 2 years is not recommended. This is also a questionable, always a debatable issue in which we happen to discuss in each and every conference, whether the booster dose should be given or not. Let us try to throw some light during the course of this talk. Now, there are available vaccines which are presently in the market is TCV-TT, that means a typhoid conjugated vaccine, which is conjugated to the tetanus toxoid. There is a typhoid conjugated vaccine, which is conjugated to diphtheria toxoid, and there is TCV, which is conjugated to CRM197. So these are carrier proteins which conjugate these polysaccharide molecules together. Now, what is the recent ACVIP recommendation regarding typhoid vaccines? Now, what ACVIP is saying that single dose of TCV is recommended at present. So there's no question of giving a booster dose or the second dose. Age group between 6 months to 45 years, preferable age group. This is for the programmatic reason. We can club it up with MMR at the age of 9 months and we can give it. IAP advises catch-up vaccination. Those who haven't received this vaccine before should be given this vaccine till 18 years of age for a catch-up purpose. There is no scientific evidence regarding need of booster dose at present, particularly in endemic countries where this vaccine is advised. That is because we have found that yes, this particular vaccine is definitely a boostable vaccine by giving multiple dosages. But then when you have an endemic country like India, where you have a subclinical natural boosting, we don't require the second dose. Now, 7 years follow-up data after TCV by Bharat Biotech study shows adequate antibody titers well above the cutoff. So that means even after 7 years, we have antibody titers way above the protection level, and that is the reason why we do not go for the second dose. So which different vaccines are available presently are type bar TCV, that is from Bharat Biotech. It again a conjugated vaccine conjugated to tetanus toxoid with a dose of 25 micrograms. Second is Zyvac TCV from Cadila. Third is Entroshield, which is again a conjugated from Abbott. Fourth one is Biovac TCV, that is Dr. Reddy's, and this is a conjugated typhoid vaccine. Then we have a Typhi-B, which is a new kid on the block. It's again a conjugated vaccine. This year, the conjugation is with CRM197. And the other attribute to this particular vaccine is here the source of polysaccharide is Citrobacter frindae, which is actually said to be very less stringent for biosafety levels. And that's the reason why it is perhaps more easily acceptable. And then there were two different vaccines which went out of the market, was Pedatype and Vac-T, which had 5 micrograms and which are no longer available. Now, there are these unconjugated or polysaccharide vaccines. I do not want to discuss about them because I feel that the technology has upgraded. Now, conjugate vaccines have taken place of these polysaccharide vaccines. So these polysaccharide vaccines, by virtue of their some drawbacks, they will never no longer be available as far as typhoid is concerned. Typhoid, typhoid VI, type bar, and biotype. Now, what is the difference between a conjugated and polysaccharide vaccines? We know that a conjugated vaccine can be used below 2 years of age, where the disease burden is very high. In case of typhoid, we have seen that the estimates of proportion of disease burden has shown that almost 14 to 29% of prevalence is below 5 years of age. Out of that, 30% almost are below 2 years, and almost 10% of cases come below 1 year. So that means we need to target these kids who are below 1 year. So this vaccine needs to be given after 6 months and can be given up to 45 years, whereas this polysaccharide vaccine or unconjugated vaccine cannot be given after below 2 years of age. Now, this conjugated is T-cell dependent and the polysaccharide is T-cell independent. Now, this immune response, it induces higher avidity of antibodies when it comes to a conjugated vaccines. So it has a higher avidity, it has probably a better isotope switching also, and affinity maturation is also better with conjugated vaccines. So that is the reason why this particular vaccine is better than the polysaccharide. It has a better IgG response as compared to the polysaccharide. Then memory cell response, yes, T cell response is vital in case of conjugated vaccine, which is not there in unconjugated vaccines. This conjugated vaccine is boostable, as I said, and probably not the boosters dose per se, but even the subclinical infections, natural infections also keep on boosting this. So the duration of protection is prolonged because of the prolonged IgG response. Repeat dose is not needed because the GMT titers really show beyond the cutoff levels for more than 7-10 years. Then the make VI polysaccharide conjugated to tetanus toxide, CRM-197, and diphtheria toxide. The route of administration is intramuscular. Here in polysaccharide, we can give it IM or SC or subcutaneously. And efficacy-wise, as I said, between 81 to 87% in case of conjugated vaccines, whereas the efficacy is not as good as compared to conjugated in case of polysaccharides. It is between 55 to 74%. Now, TCP, 1 dose or 2 dosages. This dilemma will always haunt us. And what is the take on this? The recommendation for single dose typhoid vaccine is based on persistence of GMT titers above the postulated protective titers, which is said to be 3.5 or 4.3 microgram per ml beyond 5 years of age, even in unboosted subjects. This was an open-label trial which was done by Typhoid TCB by Bharat Biotech. Now, the seroconversion and GMC show a rise after initial decline, indicating the natural boosting, and there may be a less opportunity for natural boosting in young children below 2 years of age. So this is one hitch here. No, there was initial drop and then initial decline, and then this GMT titer showed the rise. In the initial 2 years, the natural boosting is not so much because the child is at home, not moving around. So probably there was this initial decline, and then the subsequent rise in the GMC titers because of the natural boosting. Now, the avidity of antibodies is also less in unboosted subjects, whereas there is certain immunological edifices, which is, the lack of these edifices needed for providing a long-term immunity owing to the immaturity of immune system below 2 years of age. Typhoid is inoculum-based bacterial infection. So you have a more the bacterial effect or more the concentration of bacteria. The disease probably is based on this inoculum-based vaccine. So sometimes even the single dose of vaccine may not be able to prevent this disease, and you can have a child suffering from typhoid disease even after taking 1 dose. Now, for the best proportion of a child below 2 years of age, 2 doses were also under consideration, but recent ACVIP and WHO recommendations are for single dose. So as far as the schedule for the dosages, only single dose is recommended, not the second booster dose. Can an individual who has received TCV vaccine still get a typhoid disease? As I said, no natural infection gives you 100% protection. Forget about vaccines. There's no vaccine which gives you 100% protection. So when you range efficacy between 81% to 87%, there's bound to be few cases which, despite giving a vaccine, going to have typhoid disease. So yes, efficacy of typhoid vaccine is in the range of 81 to 87%. Many studies which were conducted by Biotech on type bar, there was a Nepal study, Bangladesh study, Malaysian studies were available, which showed that the efficacy ranges between 80 to 87%. The efficacy of typhoid vaccine is based on other factors, also like, as I said, host factors. Somebody is immunocompromised. There's a genetic factors also play a role in it. Innate immunity, someone has a poor innate immunity. Someone has a heavily leaden infection because of this inoculum effect is playing a role. Then there are gut factors. There is natural boosting, which was probably not very much available for a kid below 2 years of age. And that's how, there are a lot of factors which play a role. Efficacy in high avidity antibody presence also plays a role. So now let us talk about some scenarios. Whereas this R is 9-month-old and has come for MMR vaccine. Can she be administered the TCV at the same time? Initially, we said that this TCV should not be co-administered with MMR, but then there are studies, those studies are called as non-inferiority or no inferior response studies, and these studies showed that the anti-VI IgG antibody titers and anti-measles antibody titer, IgG antibody titers, were not affected when they were co-administered. So that's the reason why, yes, there is no immune interference when these two vaccines are given together. So we can give these two vaccines together on the same day. 3 years old S had received typhoid polysaccharide vaccine. Can he be given the TCV? And if yes, when? He has already received typhoid polysaccharide vaccine. Should we be giving him a conjugate vaccine? Yes, why not? We should be giving him a typhoid conjugate vaccine for a better protection. This acts like a booster to this particular child. But only thing is there should be a gap of 4 weeks. After giving this polysaccharide vaccine, you can give, and there's only, if he has received already a polysaccharide vaccine before, he should be receiving only single dose of typhoid, that after 4 weeks of gap. Now, apart from children who are other beneficiaries for this typhoid vaccine, who all should receive this particular vaccine? Now, we all know that typhoid is a disease, a foodborne disease, waterborne disease. So all those travelers who are traveling, all those who have habit of eating at every nook and corner of the city, and those kids who are into the dormitories, and the school-going children who live in dormitories, and those attending melas, yatras, large gatherings together, food handlers, microbiological lab workers, so and household contacts who are documented carriers rate. We have millions of typhoid Marys in our country, so that's also should be taken care of. So these are the people who should get this vaccine. Now, different make of vaccines are available. We know that there are different companies which have brought different conjugated vaccines. One has been conjugating it to a diphtheria toxoid. The other is conjugating it with tetanus toxoid. Third one is conjugating it with CRM197. So there are a lot of different companies which have come up with different conjugation carrier proteins. So which one we should choose? So actually, and ideally, clinically, all are equivalent, and anyone can use any vaccine. They all are almost similar, and there's no difference if you use one over the other. Now, does an unvaccinated child who has suffered from a natural typhoid illness need a TCV? Of course, because as I said, even the natural disease will not give you a protection for lifelong. Being a bacterial disease also does not give you a guarantee of protecting you. In fact, in case of virals, we have a prolonged protection for some viral illnesses. But for bacterial, we know that there is always a chance of relapse and recurrence of a disease. So here, when a child comes out of a natural infection, you have treated him, that's the right time to give this particular vaccine. A TCV is advisable to be given to such patient. A TCV can be given anytime after successful completion of treatment in convalescent phase. Now, does typhoid conjugate vaccine give protection against paratyphoid A or paratyphoid B? Obviously not. This particular typhoid conjugate vaccine does not protect you against paratyphoid A or paratyphoid B, but there are new vaccines which are coming on a platform. There are new vaccines which are already in phase 2 and phase 3 trials, and they are more reassuring. They probably would be taking care of your kids against typhoid and paratyphoid A and B. So the new vaccines probably would be launched very soon. So these are the vaccines which are available in the market: Typhoid, Zydac, the Zydus Cadilla's Zyvac TCV, the Biovac, then there is Typbar TCV, then there's Entroshield. So a lot of new vaccines have been there. Now, touching upon the other vaccine, hepatitis A vaccine, this particular vaccine was truly an optional vaccine few decades before. Now, when we talk about an epidemiological shift, this particular vaccine has become more relevant and more important to the society. Now, there is much of hype we are talking about this particular vaccine. Now, which different vaccines are available against hepatitis A? There are killed vaccines, and there is a live attenuated vaccine. There are 2-3 different killed vaccines or inactivated vaccines, and there's only one live attenuated vaccine. This killed inactivated vaccine, which is formaldehyde inactivated, comes with a strain of HM175 GBM strain. There's this only one particular strain which is available. 2-dose schedule with the interval between the 2 dosages should be between 6 to 12 months. 2 dosages induce protective efficacies of more than 90 to 95%. Long-lasting, possibly lifelong. The mathematical model showed that, yes, they give you protection for almost more than 40 years. So protection is lifelong, almost lifelong, very useful for post-exposure prophylaxis. Mind me, this particular inactivated vaccine is good for post-exposure because this hepatitis A has a prolonged incubation period. So up to 2 weeks, even if somebody is exposed to hepatitis A, he can take this vaccine to prevent getting this disease. Now, there are a lot of 3-4 different vaccines licensed all over the world. The hybrids, Avaxin from Sanofi, HappyBev from Helium, Biological E, and there's HaveShield. Now, coming to this live attenuated, this comes with an H2 strain, the LA1 strains, again from the same HM175 strain, comes with a diploid cells developed and manufactured in China, single dose 0.5 ml subcutaneously above 12 months of age. One dose elicits almost protective responses more than 95%. Long-lasting, more than 15 years of data is available. No data regarding efficacy for post-exposure prophylaxis. It can be given as a post-exposure prophylaxis, but not much of data is available. So when it comes to post-exposure prophylaxis, I think we are more comfortable giving inactivated vaccines for that. And this live attenuated, being a live attenuated vaccine, cannot be or should not be used in immunocompromised patients. The brand available is Biovac A, which comes from Reddy's Laboratories. So there are two Ds, killed and live. Killed, we know, Avaxin, Havrix, HappyBev, HaveShield, and Biovac A as a live vaccine. Now, how many doses are recommended for hepatitis A vaccine? So there is, the schedule for this particular vaccine is to be given 2 dosages, 6 to 12 months apart for all inactivated vaccines. For in live vaccines, you have to give only 1 vaccine. Havrix and Avaxin is the pediatric formulations. They have an adult formulation as well, whereas HappyBev and HaveShield do not have an adult formulation. They can be used till 15 years of age as a single formulation. For live vaccines, only a single dose, the same dose to be given for adult formulation also. No boosters are recommended for hepatitis A live vaccine. Now, if more than 12 months has elapsed after the first dose of inactivated hepatitis A vaccine, should we be giving the second dose or not? Is there any need to restart the vaccines? No, obviously not. The second dose has to be given here and no need to restart the schedule. So whenever that you probably remember that this vaccine has been forgotten, you should give it at that particular time. Now, which high-risk groups should receive hepatitis A vaccines? We know that this particular vaccine is vital in case of immunocompromised patients, in case of kids who have chronic diseases like chronic liver disease, chronic hepatitis B and hepatitis C carriers, congenital or acquired immunodeficiency syndromes, where you should and be using only inactivated vaccine. Then those cases where transplant recipients with adolescents who were seronegative and need HIV because they are living from home for their residential schools, they may be living into dormitories, in a crowded premises. So that's when, if this disease occurs, it is going to be a more detrimental. So that's the time when you need to give these kids. Travelers who travel to the high endemic countries like hepatitis A, high endemic country like India, household contacts of patients with acute HIV infection within 14 days of onset of the index case. A mother of 2 kids, one aged 8 months, the other 3 years, was diagnosed with hepatitis A. Now, the mother is diagnosed as hepatitis A. She has 2 kids, one is 8 months and another is 3 years. Now, how will you protect the 3-year-old child? So this 3-year-old child much lies between the age group of 6 months to 45 years. So here, what we should be giving? We should be giving a vaccine if the child has not received vaccine previously. So vaccine becomes the most important prevention aspect here. Now, how will you protect a child who's 8-month-old? Now, the mother was seronegative. That means there were no maternal antibodies transferred to this baby. Now, this baby is in contact with the mother who has developed hepatitis A. Now, if at all this child needs to be given a post-exposure prophylaxis here, vaccine cannot be given because vaccines, the earliest time when we can give this vaccine is about 12 months. Now, what remains to be given and which can prevent this child getting this disease is immunoglobulins. So first case, 3 years old, we can give vaccine. Second case, we can give immunoglobulins. Now, when are boosters needed? Now, the second dose of hepatitis A, when it's to be given? Now, all chronic liver diseases and immunocompromised cases. Now, children are exposed naturally in early life, then what is the need for vaccination? We know hepatitis per se is almost 50 to 90% cases. When in countries like high endemic countries like India, we all get cases between almost 50 to 90% cases happen below 5 years of age. And below 5 years of age, most of these kids have a symptomatic disease. So, and they have a natural exposure because it is a highly endemic country. Now, if they are exposed naturally, should we be giving them a vaccine? That's a big question. Now, India is high endemic. Due to improved hygiene and sanitation, now this country is actually shifting itself to intermediate or low endemic side. Second thing is, India is a country with multiple domains. Like, some part of India is already into high endemic zone. Some part of India is very highly sanitized. They have a rich population. The areas are very well educated people around. So that pocket becomes an low endemic pocket. So this country simultaneously has different endemicity, and overall this country, by virtue of its economical development, transferring itself from high endemic to intermediate and low endemic. When a country is transferring from high to low, intermediate and low endemic country, now this is the time when the disease is shifting from early childhood to almost adolescents and adults. And believe me, when this disease occurs below 5 years, it is almost asymptomatic. But when this disease occurs in adolescents and adults, this disease becomes more symptomatic. More number of liver cell failures or acute fulminant hepatitis comes with elder age. And that's the reason why now when this disease is shifting towards the adolescents and older kids, older people, we need to vaccinate these people, because vaccinate our kids, because then only these people would be protected. So that's the reason why the epidemiological shift is playing a big role. Now, post-exposure prophylaxis, as I said, 12 months to 40 years of age, between this window, if someone has exposed to this disease index case, give him vaccine within 2 weeks after exposure. If he's above 40 years of age, immunoglobulin should be taken into consideration instead of vaccine. If the other risk factors associated with as immunocompromised, we may have to be given immunoglobulins and vaccines. Less than 12 months, again, we need to give him immunoglobulins 0.02 ml per kg intramuscularly. So 80 to 87% efficacy of PEP with vaccine or IG in preventing symptomatic disease. Both killed and live vaccine can be used, but as I said, the data is not much available with live vaccines, so comfortably the killed vaccines could be given. Now, 15-year-old boy is brought for hepatitis A vaccine as he is shifting to a hostel. So an adolescent boy who was not given vaccine before, that means he's a seronegative boy. Now this boy is shifting from home to hostel, as I said. Now there is no past history of jaundice, not vaccinated, so no natural infection, not vaccinated, from a middle class family. That means he is likely to get into the exposure. So here we are supposed to give this child a direct vaccination, or one can do away with doing an anti-hepatitis IgG antibody titers first and then decide about giving away, because he may have been exposed as a natural exposure to this disease. But doing an anti-hepatitis A IgG antibody becomes a costly affair, and then giving a vaccine. So rather, give a vaccine doesn't really, create a problem for that child. Testing for antibody titer generally not required through ACVP, though ACVP recommends to do it and then give a vaccine after 10 years of age. A level above 20 international units per ml is suggested. The range is almost 10 to 33 international units per ml. That is said to be a protective level. Vaccination in already immune is not associated with any adverse effect. So even if he had a natural infection, even if he had received the vaccine and doesn't remember about it, and even if you give him a vaccine, that is not going to cause any kind of a problem. So these are the vaccines which are available. Hepatitis A, the inactivated Havric 720 junior, Evaxime, Biovac A, which is a live attenuated vaccine, Happy Brief, and Have Shield. So these were all the vaccines which are available in our country, and that is how hepatitis A vaccine becomes more vital, more important when considering this epidemiological shift. Thank you so much.
Back
Thank
to
you, sir,
Sagar
for
ji.
the time. So, Dr. Surendranath, sir?
I think he is not there. No, he's there but muted.
Sir, your voice is breaking. Surendranath, sir, please unmute yourself.
Yes.
No, sir, we still can't hear you. So, I think by the time Surendranath sir is back online, I'll ask you questions he himself has posted on the chat box. So, question to you, Dr. Basavara sir, can we give varicella vaccine as a post-exposure prophylaxis to a child who is 1 year of age?
See, as far as the things is concerned, if the exposure is less than 5 days, answer is yes, you can give it. If it is less than 3 days, the efficacy will be almost, it is around 90%. With the less than 3 days, it is 90%. Behind 3 days, it is around 60-70%. Yes, we can give it.
But even if, let us say, the days have crossed and let us 7 days have crossed, 8 days have crossed, can I give it or can I not?
See, if the age of the child is more than 1 year, definitely you need to give the vaccination. And also, if it is a post-exposure, the efficacy, we may not be knowing how much it is going to give it. Still, you can give it.
Still we can. Right. So there is this question that there is a newborn, the age has not been mentioned, but let us say an infant of 3 months or 4 months who had varicella disease, but it was a mild disease. So let us say there were hardly 40-50 lesions. Now, does that infant require a varicella vaccine?
See, basically, when the child is exposed to the varicella and developed in a chickenpox, whether it's a mild, moderate, severe, it is going to give a lifelong immunity if the disease per se is concerned. Even if it is a breakthrough varicella, following this, it is almost like a similar to the breakthrough varicella, because whatever the mother antibody which is there, that's giving us some protection. On top of that, this infection is occurred. Yes, it is going to give a protection. No need for the vaccination if you are certain that yes, it's a case of a varicella.
Right. So there was this earlier concept that if a varicella disease occurs in an infant less than 1 year, he might not seroconvert. And there was this old recommendation that these infants need vaccine, but that recommendation is no longer valid now. There is no need for a vaccine, even if the infant or a child less than 1 year gets varicella. Surendra sir, are you back online?
Yes, sorry very much. Mute.
Sir,
Unmute.
unmute, sir. Sir, unmute yourself, sir.
Sagar, you can continue the questions. Chat box, there are questions are there.
You continue. Continue.
You can continue, sir. I am on the phone.
Okay. So I'll continue. So Surendra sir, many times what happens that a person is given immunoglobulin. Let us say the person was given a immunoglobulin for Kawasaki disease in a dose of 1 gram per kg. So what should be the interval between that immunoglobulin and giving a live hepatitis A vaccine? Basavara.
Yeah. See, basically, when your immunoglobulin, if it is given a 400 milligram per kg, that's the time where you can wait for 3 to 5 months. After that, you can give the vaccination. That's the recommendation. If the immunoglobulin is given 1 to 2 gram per kg, generally for Kawasaki disease, ITP and all, we give a 1 to 2 gram per kg, GBS and all. In that situation, live vaccine better to be avoided for at least 8 to 11 months. 11 months is the thing.
So it depends on the dose of immunoglobulin, what gap exactly we have to keep. Many times what happens, Ganesh sir, the question for you, hepatitis A, many times what happens that some brands of hepatitis A vaccines are not available. Let us say Havrix is not in market. So should I give a live hepatitis A vaccine as a second dose? Can I do it?
Ideally, it is not recommended, but because that unnecessarily increases the cost of the vaccine, because second kill vaccine is that way much cheaper than the live vaccine. But yes, you can immunologically you can give it, no problem for that. If you don't remember which vaccine was given before, and in that scenario, if you want to give and if you only have a live vaccine with you, you do not have a kill vaccine with you, then definitely you can give.
Okay. And now 4 different brands of kill vaccines are available. So if at all some such thing happen, I think you can use another killed vaccine as a booster dose. That
Yes,
will be
yes, that was
better.
more pertinent.
If I give a live hepatitis A, that will be completion of series because as far as live is concerned, only a
Yes.
single. There is this question that up to what age we can give live hepatitis A vaccine? Any such recommendation written anywhere?
Up to 18 years you can give it. You can, that way you can give it up to 45 years also. Only thing is what you need to check is whether this person is immunocompromised or not, or whether he is having some contraindications to be given for live vaccine. That's the only thing that you need to check. Otherwise you can give.
Right. So there is no such age limit for giving a live hepatitis A vaccine. You can give it in 55, 60-year old also. Definitely, as sir has said that in elderly, especially you have to see whether the elderly is having some immunosuppression, because many of the elderly have some immunosuppressive diseases in them. So preferably you can offer them then killed hepatitis A if at all you want to give that vaccine in an elderly person. Because I have not gone to any such recommendation about age limit.
Yes.
Basavaraj sir,
Yeah.
that IAP say that don't give vaccine to all children. If the meningococcal vaccine is not recommended, there are some states and some areas where the pediatricians themselves are worried. Let us say like West Bengal or some parts of UP, some parts of B. They say that this IAP recommendation does not suit them. So should
See,
they?
as far as the recommendation of ACVAP is concerned, I got your point, Dr. Sagarji. As far as the meningococcal vaccine is concerned, what IAP stands is what WHO position paper of 2011, what it clearly says is, it is India is comes under a low endemic countries, so low risk category. It is less than 2 per lakh population. That is when you are recommending for a public use, that is the situation. AAP clearly says it is not no specific recommendation except in a risk factor is there. That is the situation where high risk children given a meningococcal vaccine, and travelers is anything. That is the general recommendation. Coming back to your question, suppose if there are states where they are getting in a meningococcal vaccine in south, what we get it in Andhra Pradesh, where the published report which is available, and also in northern part of India where the published report is available. If the people are vaccinating there, you cannot say don't give it. You can give it.
Okay. And there is this
And
dilemma.
also, you will be the better person to further expand that.
And there, many times there is a dilemma in office practice that a parent comes to you and he says, sir, give all the vaccines which are available with you in your kit. So if he says such a sentence, do you offer meningococcal vaccines to these children?
Definitely, I'll do. Once the parents are demanding, if the vaccine is available, licensed vaccine is available, I'll never say no to it, but I'll reveal all the information. India is the low risk country. But however, since you are moving everywhere, if you are asking it, finance is not the issue. I'll give it.
Definitely. So one-to-one discussion will be the best way out, and let the parent decide what exactly should do. Meningococcal vaccination and overcrowding, or those living in hostels and dormitories. What is the relation?
See, especially in a overcrowding, especially in a schools, hostels, colleges, this is the place where US is also recommend that this is an overcrowding area where the meningococcal things and social gathering. This is the place where Hajj pilgrims is another thing where we do recommend a vaccination in that category. In that situation, answer is yes. Especially if a few cases have been reported in that area, overcrowding is there. Definitely, it is ideal to give a vaccine.
And nasopharyngeal, the spread of nasopharyngeal carriage is very high, and that is why it is always said that you have to give meningococcal conjugate vaccine, and that is why we never offer unconjugated vaccines to these children going to universities or going to reside in hostels or in dormitories. That is the basic reason. Ganesh Kulkarni sir, there is always a confusion. Many times these students who are going to US come to you, their age is 20, 21 years, but there is no killed vaccine for them. So what are the age cutoffs for average, for happy beard, for half child, and the son of his vaccine? What are the age cutoffs beyond which we should not be giving? Because recently I saw many pediatricians, they give this pediatric vaccine to a adult. What is your opinion? Ganesh sir. Is he there? I think we have lost it. Basara sir, can you take it?
I did not. Can you come again?
What are the age cutoffs for killed hepatitis A vaccine?
Hepatitis A vaccine.
Yeah.
Okay. See, as far as the things is concerned, there's no cut of this one. 1 year and above, generally we can give it.
So 1 year and above, you can give it. Especially what I wanted to ask was that, like, average junior, it is allowed till the age of 18%. The vaccine, which is from Sanofi, it is allowed till the age of 15 years only, the 18 unit formulation. The Happy Bee and Hapsil, they are licensed till 15 years old.
Okay.
So if there is a adult, let us say 18 years and above, you cannot offer him a Happy Bee or a Havrix or a vaccine for that purpose. And for those children specifically, you will have to give a live hepatitis A vaccine because the formulation is same in pediatric as well as adult.
Yeah. So basically, we need to stick to the specific brand. If it is not available, that's the situation where you can.
That is a very tricky situation. Now, there were some experts who used to say that you can take 2 vials of Havrix and give it on 2 different arms or 2 different locations and say that you have completed an adult dose. But again, that is a tricky part. So, any other question from any other expert to be discussed? Surendra sir?
Yeah, I think we can close for today if there are no questions on that box.
Yeah, no, I don't see any more questions on chat box, and I think it was a very, very fruitful discussion, and today it was really very interactive session.
Only one question. Is there any guidelines for giving a vaccine for those who receive the immunoglobulin, or is it the same for varicella?
Sir, I cannot hear you, sir.
If somebody has received an immunoglobulin, IV, IgG, or hepatitis A immunoglobulin.
Answer that question.
Hello?
Basara sir has answered
Because
that part.
all. Yeah, okay. Okay, I think we can meet tomorrow.
Yeah.
And
So
I thank all the faculty who have.
Yes, sir.
Thank you very much, Dr.
I thank the DAP. Yes, sir. I thank Central IAP President Dr. Kinjivadkar, President-elect Baswaraj, Vineet sir, and our treasurer for giving this opportunity on a DIAP platform, and the module which has been prepared very well by the Sagar Kulkarni, and it is very useful for everybody. Thank you very much. We'll meet tomorrow.
Thank you, sir, and we'll see you tomorrow at 2 p.m. sharp. Thank you.
Yes, sir. Yes. Okay, sir.